I am Patrick Serruys from Rotterdam. We are in the studio of the European Heart Journal in Barcelona at the EHJ, the European Society of Cardiology Congress. And I have the pleasure to have with me Thomas Pilgrim. Thomas is going to present a late-breaking session in the upcoming hours. Can you tell us about your trial and what you're going to present?
Yes, thank you. So the BIOSCIENCE trial was a randomized controlled non-inferiority trial comparing an ultrathin strut biodegradable polymer sirolimus-eluting stent with a durable polymer everolimus-eluting stent in a patient population with minimal exclusion criteria. So more than 2,100 patients across 9 hospitals in Switzerland were randomly allocated in a 1-to-1 ratio to treatment to either the Orsiro stent, the biodegradable polymer sirolimus-eluting stent.
It's a lot of information for a simple mind like me. So basically this is an all-comers trial. So Stefan, your boss, is pursuing this tradition of all-comers, and if you do all-comers is because you believe that the technology that you are using is extremely competitive and can face all the situation. Is that a good statement?
Exactly, that's exactly true. The trial was designed as an all-comers trial, and we think that the biodegradable polymer sirolimus-eluting stent is competitive with the durable polymer everolimus-eluting stent.
Before that, in 2006, if my memory is correct, there was already a trial called LEADERS with biodegradable abluminal versus a durable coating. Why 8 years ago, 8 years later, do something similar? I mean, what do you expect as a basic change with the first generation?
Exactly. So this is like the next generation of biodegradable polymer sirolimus-eluting stents, whereas in the LEADERS trial, the biodegradable polymer biolimus-eluting stent was based on a stainless steel platform with a strut thickness of approximately 120 micrometers. The Orsiro stent, the biodegradable polymer sirolimus-eluting stent used in the BIOSCIENCE study, is based on a thin strut, on an ultra-thin strut cobalt chromium platform with a strut thickness of only 60 micrometers.
So 60 must be a limit, because at some point you have to take care of the radial force, you have to take care of the recoil. Is that the lowest level they could go by combining, by getting this alloy?
Well, this is a difficult question for me to answer. I think so far this is the thinnest strut thickness we have in metallic drug-eluting stents, and at this point I cannot tell you if we can.
And it's good to have something thin. That's your assumption.
Exactly. I mean, we hope that the arterial injury might be decreased by an ultra-thin stent platform, that maybe peripheral embolization or side branch occlusion may be reduced by the ultra-thin stent platform. But I understand that the radial strength and also visibility may be an issue, but that's something that we haven't observed in our trial.
Before looking at the, listening to you on the result, these thin struts, you say potentially less injury, but as a simple guy like me, when you have a wire and butter, and I'm thinking about vulnerable plaque, is it possible that the wire cut through the butter? Could we have the reverse effect, have the sudden embedment of these struts in the necrotic core?
Well, maybe that's also a possibility. We don't know at this stage. However, in the bare metal stent era, we have observed that the thinner stent strut had a benefit over thicker stent strut, also in terms of restenosis, for example. So therefore, I think it's reasonable to design stent struts with very thin stent struts.
That was the seminal observation of München with Schömich and the multi-link at that time. Good. So this, you set the stage, all comers, big numbers. Primary endpoint?
The primary endpoint was target lesion failure, which was a composite of cardiac death, target vessel myocardial infarction, and clinically indicated target lesion revascularization at 12 months.
Okay, so in our jargon, in the jargon of the ARC, consensus is device-oriented composite endpoint.
Exactly, it was device-oriented composite.
Why not patient-oriented endpoint, a POC, as they said?
Well, this would also have been a good possibility. So we decided to use this device-oriented endpoint to assess the new device that hasn't been tested before. Patient-oriented outcomes are also very important, of course, and this has also been assessed, but we powered the analysis and the entire trial for a device-oriented endpoint.
So I've read that one has silicon carbide, kind of base coating in silicon carbide, and the other has a mixture of fluoropolymer, but there is also polybutyl methacrylate, which is still there. We don't like too much the methacrylate. I mean, we have bad experience with the Cypher. Can you tell more about the coating, the amount of drug, and...
Yeah, exactly. So the Orsiro stent, the biodegradable polymer sirolimus-eluting stent, has actually a passive coating consisting of a silicon carbide layer that kind of seals the bare metal stent surface once the biodegradable polymer that is also there is completely degraded after a duration of 12 to 24 months. The biodegradable polymer used in the Orsiro stent is a poly-L lactic acid polymer that, as said, elutes sirolimus over a duration of 3 to 4 months and degrades thereafter over 12 to 24 months.
You know, in the leaders, we knew that with time the biometrics will be the winner, because the polylactide will disappear and we will be back to a bare metal stent. But here you are facing the science, and the science has already very, very good reputation, even the long term, with these permanent coatings. So what are you expecting in addition this time?
Yes, that's a very important issue, and that's true. And that was also the reason why we wanted to test the Orsiro stent versus the current benchmark in safety and efficacy to the Xience stent. I think, I mean, biodegradable polymers have or may attenuate this inflammatory response after stent implantation, this inflammatory response in the vessel wall, and maybe during long term we might see an effect, as we have seen this in the LEADERS trial, or also among patients with an inflammatory milieu, such as ST segment elevation myocardial infarction patients. They may benefit from a biodegradable polymer drug-eluting stent.
So, result, if I remember well, 6.7 target lesion failure, exactly the same. Anything which make the difference? I went to the forest plot there. I saw something on the STEMI, but small numbers, very small numbers. So I would not put too much emphasis about that. You change from group 2 or 3 patient, and the p-value for interaction probably will disappear. Tell me, what are we going to continue to do this kind of trial, non-inferiority in the range of 4, 5, 6%, or we are coming a little bit at the end of this discussion? You have said the essence of your finding. How do you see the future? I mean, are we going to do a non-inferiority on 4%, 3%, 2%, and then stop the game, or do you see the future differently as a young cardiologist?
Well, that's an extremely good question. I like the question very much, even though I don't have a perfect answer to the question. So I think with the excellent outcomes we have with contemporary drug-eluting stents, it will be more and more difficult to establish superiority for newer stents. So therefore, I think it will be common to do non-inferiority trials. And if we look at recent trials, stent trials, most of them were non-inferiority trials. But what we can expect that we see during long-term follow-up may be a difference, as we have seen superiority in the LEADERS trial, that we can expect something during longer-term follow-up.
Right. But we are still basically counting the failure. We are counting the death, the MI, the restenosis, the thrombose, that we are counting. What I would like to see at some point is that we go for what is beneficial for the patient. They came with angina pectoris, and basically 75% leave the scene without angina pectoris, but 25 stay with angina pectoris, good or bad stent. What is your response? I mean, are you interrogated by that aspect of our medicine that 25% of the case, we have no solution despite the good stent? How do you see that?
Yeah, I mean,
it's the end of the interview, so that will be your testament.
No, I mean, I don't know. I think it's always good to have hard endpoints for clinical trials, and it's definitely much easier to compare a stent with regards to hard endpoints such as death and myocardial infarction, and that's also what we want to know first. And then, of course, we might want to have a clinical benefit in terms of clinical symptoms, but I think first we have to establish safety, and then comes efficacy, of course. Yeah.
Okay, young men like me will tell you that I go now for more and more the symptoms, because there's still 25% to gain versus 5%. There is some beef there. Thank you very much. It was very good. I really appreciate it. It was very clear and precise. Thank you very much, and European Society and the European Heart Journal.